scapula. Okay, so I'm coming in with my hand. You can either cup at the upper trap here, okay, or you simply could block the scapula by putting your palm down on the table. I'm getting close in with a patient. If you guys are manually trained, you've got to get in close with your patients. I'll have that patient rest their humerus on my leg closest to the table while stabilizing their scapula. You want to bring the wrist, the fingers, and the thumb into extension while externally rotating the shoulder, and then drop them down into some elbow extension. How does that feel? Okay. If this reproduced the patient's chief complaint, I would ask him to, can you side bend away? Does that start to increase your symptoms even more? If so, let's back off. And we would constitute that as a positive test, assuming that this didn't reproduce that chief complaint. Okay? Now, if that reproduced his chief complaint, I would keep his neck at neutral here. Keep him in the same position, except for I typically will bring the wrist back to neutral. So I take the tension off in an adjacent joint while just bringing his elbow into some passive extension. I tend to do this by not just controlling the arm, but I tend to kind of rock with it. So I'm just rocking it onto my lead leg. How does that feel? Good. So that would be my mobilization or gliding of the nerve. You don't want to just keep bringing them into tension because then you're mechanically compromising, shutting off some blood supply to that nerve. So decrease a little bit of that compromise and just bring them into elbow extension. Good? You guys want to give that a shot?